So why am I here? And what are my credentials? So the quick on the background, you all can look me up, GailZahtz.com. I have been a serial entrepreneur myself. I have been in y'all's shoes asking for money, begging and pleading for money. My first venture-funded startup was when I was 28 years old. It was in the wellness and tech space, bricks and clicks. And I thought that that was how you raise money. I was out with a client one night, and he said, "What would you do if you had some money?" I said, "How much?" He said, "I don't know, start with $1 million." And on a napkin, I wrote it down. And the next day we walked to the bank, deposited $800,000 on what ended up being a $1.8 million seed round. And I thought, money just comes from the sky. I am so smart. This is the way it always works. So I've been through 2 market crashes in my career, though, 2000 and 2008. And so I have seen the other side. I have been sitting in y'all's shoes, and I've also been sitting on the fun shoes. So in as many ways of that as I can be helpful to you, I am here to do so. Feel free to grab me before, after. I'm here through the end of the day tomorrow. The real reason why I talk all over is because I talk about value-based care and the business of healthcare in the US, which is going to be essential for you as you start thinking about, you have this amazing solution, this amazing product, you think the outcomes are amazing, but it's only as good as getting it to market. And we're going to be talking about what the market in the US looks like. And this is really my specialty, is how the money flows in the US health system. So hopefully you've come to the right place on that. We're going to dive into that. Before we do, though, I want to give you a look at my lens, and sort of the lens of all of the people at the end of the day that you are serving by having a health solution, which is the patient. 7 years ago, I was sick. I'm a single mom of 4 children, and truly single because I had left domestic violence with all 4 children under the age of 9. So when I tell you about the story that I'm about to tell you, I was really single mom doing this. And I was getting sick. I was losing some functionality. I went to the hospital. For those who know, it was Labor Day weekend. In the US, that's a big holiday where nobody's doing anything, and certainly nobody wants to staff hospitals. So my thinking at the time, I'm sure you all may be able to follow this, is it's Labor Day weekend. They're not going to want to keep me. They'll give me some drugs, fix me up, send me home, right? Well, at this point, I wasn't walking. I was losing functionality in my organs. They had no idea why. And a hospitalist comes in and says, "We've got a great place to send you to." And then gives me a piece of paper. And I'm looking at this paper. He says, "You're not safe to go home. You're not safe to take care of your children. So we're going to send you to this place." So I look at the piece of paper. I'm like, there's no physical therapy at this place. There's no care at this place. There's no rehab at this place. Are you sending me to hospice? Well, it's not exactly hospice. You know, you can always still do things with your medical team. I said, "You don't know what's wrong with me. You don't have any answer on why, but a 40-something single mom of 4, and you're sending me to die." So, being the serial entrepreneur that I am, I said, "I'd like a new plan," right? I choose next. Oh no, so they bring in a psychiatrist, right? Because it's that woman who's just being foolish, right? So we're gonna set her straight for an hour, and it's always amazing that they freed up a psychiatrist for an hour, right? He sits by my bed to get me to accept my situation, right? And use the time to write letters and videos for my children. And I said, "No, I don't like that plan either." So they bring in security, pushing a wheelchair, right? They're bringing 2 armed security officers with the wheelchair. "Oh, miss, could you get into the wheelchair, please?" I'm like, "No, make me." Right? So I know I'm in healthcare in the US, and Everything is based on bed utilization, right? You want high pay people in while they're getting expensive procedures, but then you want them out as soon as they're just on what would be called observation, which is $3,000 a day, but it's not a lot of money. So I was counting on this bed utilization person. I said, they're gonna want me out. So 6 days later of my lay-in at the hospital, they got the call and said, just get her out. So what was my winning ticket? The basement of a 1-star nursing facility. So for those who do not know the US health system, nursing facilities, skilled nursing facilities are geared from 1 to 5 stars. 5 stars is beautiful, spa. 1 star is supposed to be closed. But it's left open for one of a bunch of reasons. There was mold coming down from the ceiling, right? Dripping down, like actively dripping down. So a few weeks into this, and I'm like, what have we not done? What have we not done? What have we not thought of? And I do a self-exam, a breast self-exam. And I had asked for a mammogram a couple years before. And they said, oh no, you're too young. So I was not approved for a mammogram, but I was approved to be left to die. So I feel something. I go into primary care, Dr. Sick. I cannot make up that name. Last time I ever saw him, I went in and I'm like, could you just check this out? He's like, we should get you in for a mammogram. So he sends me for dual mammograms. They immediately do 2 biopsies, bleeding all over. They send me back to the nursing home. I get a call from scheduling. Scheduling is not your doctors and nurses. Scheduling are the administrative people that may or may not live in your state or country that are scheduling you for your next appointment. So I get a call. Remember, I'm in the wheelchair. I'm in the nursing home. I get the call from scheduling. Amazing news. We got you in with the next available oncologist. I said, oncologist? You mean I have cancer? She said, why, yes. You have aggressively metastasized ductal carcinoma. Didn't anybody tell you? I'm like, nope. So another ping in what occurred. I go in the next day. I meet with all of oncology, 3 people, and all of palliative, 3 people. And I said, so here's the deal. I'm in healthcare. I'm not going to call my colleagues for a second opinion. I'm not going to Google it. I'm not going to go do research. I will do whatever you tell me to do, but you need to know I'm in this to survive. 10 months later, I had over 50 surgeries all in. I have been cut all over. I lost my teeth. This is all reconstruction. I had 5 rounds of chemotherapy. The last one was synthetic mustard gas. For people who don't know, mustard gas is what we use in chemical warfare. So I had a chemical warfare going on inside my body. I had 10 months of the chemotherapy. They were able to shrink all of the tumors down that they were barely operable. Found an amazing surgeon who was willing to take a risk on me, as long as I signed away everything. And he said, okay, but you're not left-handed, are you? I'm like, yes, I am. He's like, of course you are. Because the tumors under my arms had gotten so big and blocked the blood flow that they didn't think they were going to be able to save my arm. So when I went in for the surgery to remove the tumors, I thought they were also taking my left arm. I woke up and I'm like, amazing news. Amazing I got this hand. But then after that, I had no more vascular system in this whole section. I had no evidence of disease, and half my teeth had already fallen out. But they needed to save my vascular system. So since I could not take a transplant of anything from the outside, we did a transplant from my own system. So we opened up my stomach, took the vascular system from my stomach and transplanted it up here to save my arm and my chest. That all went great, except I had done 4 C-sections from that same area, and so my stomach didn't close. So for 6 months, my stomach was open. It's called undermining. You could put your hand into my stomach up to your elbow and wave it around. And that's how big the hole was in my stomach. And it wouldn't close, and therefore I got C. diff, and I got MRSA, and I got a whole cocktail of amazing infections. The part of that story, though, is that I had, after a year of fighting to get my kids back, because my kids were put into foster care during all of this, because there is no place in the US system for a single parent to become sick, they are viewed as negligent. So it is negligent in the US to have the inconvenience of dying without a caregiver. So my 2 oldest children, one went to Israel, One went to Florida, but I had 2 in elementary school. And they were put with a family who could not have biological children, who thought they had won the winning ticket of getting 2 kids who were going to be available for adoption. And then I was super inconvenient that I did not die. And instead of relying on the courts and all of the professionals who were involved in the case that were given to the kids, they decided to hire their own attorneys and fight with the state and me about returning my own children. So, the hospital was great. I was at University of Minnesota, and they actually, my care was great. No, I mean, all of that happened from the same hospital, which is a great question, right? Which is that we are often looking for the bad guy in healthcare, right? The insurance company or the payer or a particular doctor. The issue in the US health system is that the entire system is fatally flawed, right? It is made up of thousands of different silos that do not talk with each other and do not work with each other. And then you have the money going from each one of these. So you have these synapses. You know, a synapse, like your brain makes a jump in your, right, over an empty hole. Those flows of communication and information and care that you would expect would happen. Your doctor talks to another doctor, you put stuff into an EHR, you went to one ER, but right down the street you went to another outpatient clinic, so everybody should have everything, right? A scheduler should not be giving a diagnosis, right? And sometimes what you all are solving to is too big, too far away from the reality that is healthcare in the US. So I hear a lot of times, because I sit on the venture side also, I get pitches all the time. And I'll hear a lot of times in people's pitches, they'll say, here's the amazing outcomes. We solved to cardiovascular disease in 5 years, 1/3 of the people aren't sick anymore, and the cost of cardiovascular disease in the US is $20 billion, and we're gonna have 10% share of that because we keep people safer and healthier in 5 years. Okay, so ladies, no one who is buying cares. No one cares if you're making someone healthier in 5 years. No one cares because no one is getting paid to care. Because if we look at how the money flows in the US health system, anybody that you're sitting across from that you're trying to sell to is concerned about their money, what they have, and what their metrics they're going to be judged on. And not one person at a hospital that you're selling to, and I'll deeply encourage you to find markets that are not hospitals, but no one at a hospital, no one at a payer, which is where a lot of the money is, no one at a clinic has any financial incentive to care what happens in 5 years clinically, because they have no idea whether or not that beneficiary, that patient, is going to be attributed to them in 5 years. So you're solving a problem possibly for one of their competitors. So when we talk about, like, how could this happen, right? Well, it's the University of Minnesota's fault. It's the hospital. It's the doctor. It's the EHR. It's those synapses. I've never used that example, but I'm going to use it again. I'm taking that with me. It's those jumps, right? That just do not happen effectively. So one of the things that you start thinking about when you think about growing and selling in the US business is that they will look at you. Look at this. We got a whole show.
And we're pitching outside.
They will. You will gain so much by becoming a trusted advisor to the very people you're trying to sell to. Which is that what we're going to be talking about in value-based care and how we move to value-based care is something that everybody in the US has to understand, and almost no one does. Okay? So, and I'm in the business of value-based care, right? So I do this all day long. And people are like, oh, well, who's your audience, right? You all have to be thinking about that. Who is your ideal buyer? And you should, what do they eat for breakfast? What do they wear? I mean, seriously, think about who your ideal buyer is and why they want to buy from you. So my ideal buyer, my ideal customer, I call him Joe. Let's make him a man. And he has been with this pay provider, which is, we'll talk about what a pay provider is versus a payer or a provider. It's a made-up word. But he's been there for 15 years, right? And that pay provider in their contracting department put in a whole bunch of applications to CMS, Centers for Medicare and Medicaid Services. And then they get a notice that they won this huge value-based contract that starts 1/1 next year. They're going to have 50,000 beneficiaries. And the CEO or the board or whoever gets the notice is like, oh my, we need someone to run this, right? So it says, well, Joe's been a good soldier, right? Joel's been with the company 15 years and we can count on Joe. So they make Joe president or vice president of value-based contracting. Joe has no idea what value-based contracting is, but doesn't want to tell anybody. Right? He's concerned with two things: the company holiday party and the board meeting. Why? Why is he concerned with those two events? Because in one of those events, somebody could pull him aside and say, Joe, my neighbor just went bankrupt from an ACO. Joe, I just read this thing that came out on the news about the fact that everybody's moving to value-based care. And all Joe wants to say is, I've got this. We're fine. Doesn't even actually want to understand it so much, right? So that is my, so we're going there right now. So let's talk about how money flows. We're gonna, let me see, because this I would like to show. That was my nursing home, everybody. It looks really nice on the outside, right? Yeah. You from Minnesota?
University of Minnesota.
Okay, well, that was my place with the mold coming down. Those were my kids when I was in care. That's me.
Can we give you a round of applause for everything? Yeah.
Thank you. These were my kids in the nursing home. I will take it. Those are my kids while we were in the nursing home, me still trying to parent. That was the empty bed. So that was me. That was me, and that's me today. So, you know, we never know when we see the outside of people, right? I'll give you one more sec of that catastrophe.
So how, with what you were going through, what exactly caused that with your teeth?
So 25% of all people who go through intensive chemotherapy have significant dental damage. It causes, particularly with how much chemotherapy and radiation I was on, it causes, while it's killing the cells, it kills the roots that hold the teeth in. And fun fact, in the US health system, all reconstruction post-cancer is covered except dental. So I have a Lexus in my mouth, 12 hours of surgery, a year without eating so that I could have a mouth again. That was post-op. This was a year procedure, getting my mouth put together, and that would not have been covered. It's only if somebody can do the cash. Yeah, they're great, right? In Minnesota, yeah. So, huh? That I named? Yeah? It's Alexis, but we could call her Alexis. I'll go with that. Man, I'm going to use the synapses and Alexis from now on. So when you guys see me at my TED Talks, you'll be like, man, I know she got that. That's mine. That was my line.
I kind of feel as if you skipped to the success part without actually just sharing how from that.
So that was a question I had before I came on today. I said, do you guys want the business of healthcare, or do you want how to survive almost anything? Because I gave talks on both of those. We could dive into the business of healthcare and then go into the survival stuff, or you guys tell me, because I'm really here for you.
I think we can do healthcare today, and you're here today and tomorrow, right?
I am here today and tomorrow.
We have time.
So let's dive into healthcare, thanks. So,
Can you do it as if we are 6 years old because not all of us are American?
you know what? Here's what's great, is that you're willing to admit that. All of the American people, no one understands it. No one understands what I'm about to talk about, but they think they do. They think they do. Everybody thinks they understand this. And they're like, oh yeah, BBC, yeah, I looked at our DRGs and I'm like, oh yeah, what's a DRG? They're like, you know, I know. I know what a DRG is. You know, it's that thing. I'm like, so let's simplify it. Fee for service. Fee for service is how healthcare is paid currently 70% in the US. Fee for service acts like your mechanic. So you're walking on the sidewalk's broken. You trip, you fall, you break your arm. You go to the health clinic and they fix it and they wrap it and they call for physical therapy and they give you some medication. And each one of those touch points, like the screw that the mechanic does, each one of those gets a bill because that's a fee for the service of servicing you as your car. I call it a fee for sickness, right? Because people are only paid if you fall on the sidewalk and have an injury, then they get paid, right? So their entire incentive is to get you in there sick.
So it's free for, sorry, what is it? It's a service.
Fee for service.
So fee was fee. I like how you say that it's
I call it a fee for sickness.
fee for sickness instead of fee for good health, because we are all trying to, you see what I mean?
Yes, and now we're going to get there. So enter in value-based care.
It's actually like a lot more, it's actually a lot more specific. It's fee for your specific injury in that service. It's like, it can only be for a woman over this age that has this condition and is getting this treatment for that condition. That could be for any other condition as well.
And it's not all along that, and I don't know that we're going to have time to talk into the details because each part of the health system is paid differently. So a hospital is paid on a prospective payment system where they say they're not paying for even the service. They're saying we're paying based on a DRG, which is a diagnostic something group. And what that does is that says that this set of conditions for this kind of person has the following price, not because of what it costs to do, not because of what you theoretically would charge, but because that is what we as the government have decided it's going to cost you in resources to provide this service.
And then the insurance company can even vary that even more. The government can decide what the cost is, but each insurance will bill it different.
Yes. So there is, so it's interesting. I do a lot of talking on price transparency. People are always asking me to talk on price transparency. And I said, so here's the problem when we talk about price transparency in the US health system. There is no price. Okay. So why is there no price? Because you somebody have a pen or something? I need props. Here we go. No, I want to buy this. I want to buy this lippy thing. I want to buy a lip plumper. That's all I want is a lip plumper. Okay. So actually, maybe I'll take it. All right.
6 different colors.
Okay. So you want this lip plumper.
Yep.
I make this lip plumper. I know, I'm going to just keep saying that, plumper. I know what it costs me to make the device. I know what it puts into, I know what it's going to cost me to get it to market. And then that is my wholesale price, right? There's a price based on what it costs me to make this. And then it goes to the market in a retail price that goes to what is comparable. What are all of the other lip plumper companies selling? I know it's a good one. What are they all selling it for? And you get this kind of competitive to get to a price. The US health system does not work that way. Here's how the US health system works. It works, I am the government, all the government, just me. And I am with Centers for Medicare and Medicaid Services. So I'm responsible for determining the pricing for the base pricing for the US health system. So I am going to come up with a bunch of criteria that decides what I want to pay you. You're not going to tell me what it costs you. You're not going to give me a price and then we'll negotiate from there. No. I'm going to say, this is the set of circumstances that I am going to approve for paying for this lip plumper if I buy the lip plumper in the hospital. And there's going to be a different set of rules if I buy the lip plumper at the clinic. And there's going to be a whole different set of rules if I buy it not from a doctor, but from a nurse. But what about if I buy this lip plumper in a rural area? Oh, that's a different price. Right? You see? There is no price in the US health system. Everybody who receives money is being told that there are a bunch of rules that are going to determine how they're paid. And nobody who actually is providing services knows what those rules are. So the people creating the product and service have no say in what the price will be. The people buying the product or service, the end user of the patient or caregiver, has no say. It is all done by about 50 different agencies. There are actually 50 agencies in the US that play a part in the pricing of healthcare. 50. They do not talk to each other. Oh no, that would be way too simple. They all come up with their own rules. And then those rules filter into wherever they're being held accountable. So value-based care, what it does is says, we're going to change the finances. We're going to pay you the same amount. When it's paid in full, it's called a capitation. Capitation is like a subscription. You get a PMPM per member per month. We're going to pay you against a benchmark, which is the total cost of care that is risk adjusted. And so you're going to get the same amount whether your panel of beneficiaries is healthy or sick. So suddenly what have we done? We are incentivizing people to have a safe sidewalk. We are saying that you do better financially if you fix the sidewalk and I don't fall, because for the first time in the US health system, you're going to get paid more and be able to keep that money if you keep people well and at home. Right now, yeah, one sec. Right now, about 30 to 50% of the US health system is built this way, but here's why it matters, ladies. 100% of Medicare beneficiaries, which therefore will filter into everybody in the US, is required to be in an accountable relationship by 2030. 100% of everybody in the US is going to need to be in an accountable relationship by 2030. So what that means, So we're going to talk about what an accountable relationship is. I want to hit on health equity for a second because you're going to hear a lot on health equity. What health equity means is that you need to have a safe sidewalk in every neighborhood, right? That it doesn't matter the zip code, it doesn't matter how sick people are, it doesn't matter the color of their skin, it doesn't matter their income, that everybody in the US deserves to have a safe sidewalk. And so these three movements are going to deeply impact your decisions and your sales. So I'm going to give you a really quick overview of how we got here. We do not have enough time. In fact, I would like to be looking at the time myself so I can have an idea on timing. Oh, we went to. Okay, who's in charge here? I need the 4 o'clock slot. This is. Yeah, I got that. This will not do. All right. I'm going to jump through a bunch of this stuff and then we're going to have to pick this up. So the Social Security Act was passed in the 60s. Medicare started. Medicare originally is for people who are 65 and then added to people who are permanently disabled. Medicare is the US's bad version of social insurance for people who are 65 and over, where we had a bunch of managed care. Managed care was where we started looking at how can everybody work together under sort of a capitated relationship. The issue with managed care in the US was that there was no accountability and it was a closed network. So you couldn't go see a doctor anywhere. Because you were sold, you could only see these doctors. Medicare Advantage started in '99. You all should have a plan on how you're going to sell to Medicare Advantage. 50% of anybody who receives Medicare. CMS, guys, is the #1 insurance company in the US. CMS, Centers for Medicare and Medicaid Services, funds the majority of all health care in the US. So CMS, Centers for Medicare and Medicaid Services, is going to be an important buyer for you. Yeah?
Question, if our patient population is not over 65, is that still holding true?
So it's a great question. So CMS controls directly what happens if you have Medicare. So that, which is the #1 insurer. But CMS also impacts, because they pay at least dollar for dollar for all Medicaid and CHIP, which was created with the creation of the ACA. What that did was, for those in the US know it as Obamacare, this expanded what was Medicaid, which is insurance for the poor, so that you didn't have to be quite so poor, and moved because we had, you know, almost 50% of our children not having health insurance. Now we're down to over 85%. But to put that into perspective for a second, the US of all developed countries spends more money, more per capita in healthcare than any other developed countries, and has the worst outcomes. Of all developed countries, we have the worst infant mortality, we have the worst maternal health, we have the lowest age, we have the most aging problem, we have the most heart disease. We are not doing well. And we're spending more than any of your countries are to do that. So it's in crisis mode here in the US, which means that when you can answer to that crisis, you become a trusted advisor to your buyer. And when we talk about consultative selling, right, whether you're raising money or you're trying to get your first partner, or you've gotten some partners but now you're trying to get like the big sale, the #1 way that you can gain traction there is that everybody is trying to figure this out. And I know we're not going to be able to hit on all of it in 15 minutes, but as you learn about this for yourself, you can be like an educator for your clients. And this will make you different. So the ACA also created something called CMMI, which is an incubator to start alternative payment models. Alternative payment models and value-based care are kind of synonymous, which is how do we put together payments that are different than a traditional CPT code with an ICD-10 diagnosis and a set fee. And FYI, guys, if any of y'all's pro formas are based on CPT codes, I expect you to remove that before tomorrow, because I've seen that 1,000 times. No one is paying your CPT code. No one is paying you a set fee. You don't know what CPT code is. We're not going to be able to talk about we're not going to be able to talk about it today. A CPT code is a common procedural terminology that says, so you have an ICD-10, which is your diagnosis, and your CPT is what procedure will take care of that diagnosis that has a set parameter that we can put a price to. So the American Medical Association every year sets up what the CPT codes are and what they're going to be paid, gives that to CMS, the Centers for Medicare and Medicaid Services. They add to it and create something called HCCPS codes. Those come together and say what are the units of payment in the US.
And then the hospital hires someone to tell the doctors, don't use this one, use this one, because if you fix a cut, you only get made this much, but if you close a wound, you make this much.
Right, so, and how you code it, and how you code it.
Reimbursement based on the CPT code, you get reimbursed and...
That's how you would get reimbursed, yes, a unit based on a whole formula that goes into that. And the difference being that that is how the US health system is paid now. But as we move in the next 7 years to where everybody is in a value-based relationship, the payments are going to go differently. Here are the big goals of the US health system up to 2030, which is that all people in Part A and Part B, I don't know that we're going to get to that either, I'm so sorry. I love all your conversation input. I just feel bad that I'm a little off on time. There's so much I want to teach you guys. These are the goals. These are the big goals of the US health system. Drive accountable care, advance health equity, and you can read the rest. 2030, everybody's going to have to be in an accountable relationship. Towards that goal, CMS, here's the big goals of how they do that, which is lower cost, improve the outcomes, and make a better patient experience. So,
Just a quick question.
yeah.
Is that the reason why Walgreens has invested $5 billion into Village MD and CVS?
Yes, it is. You win the medal. In fact, you are going to see market-wise, I don't know if I have it all on this particular deck. Walt Disney moved 77,000 employees to value-based contracting in one move. If you look at the market investments, everybody's investing in value. In fact, I had a great drive here. I had, I had over a 2-hour drive, so I had my headphones in. I'm like, oh, I'll fit in some calls. And I got asked to help run a fund that's going to be doing nothing but servicing towards the Medicaid population in value-based contracts. That's how hot this is. Amazon, Walmart, Walgreens, CVS. Follow it. It is all of the money in the US is going to value-based care because people need solutions. So one way or another, as you come to understand this, you will find where your company can sit in those solutions. So what are some of the things that we're going to see? Hospital at home, home care. If you have something that can solve to people being able to stay healthy at home, whether it's the communication, the transportation, the support for the visiting nurses, anything that you can create that supports at home rather than in the hospital is going to give you a winning ticket. Anything that supports the data flow, not the data collection. We have too much data in the US. The problem is nobody knows what to do with it, right? But how do we get the right data to the right people so that we can provide care right time, right place? Because the goal in the US is to provide that care in the least restrictive environment, which is another way of saying the least expensive environment. So the other is, what can you do on transitions? Transitions of care are huge money suckers here. What's a transition? A transition is when you go from acute, which you would call a hospital, to post-acute, which would be like a nursing home or a rehab. When you go from post-acute to home. When you go from one thing to another in your care, which can be in the same building in the US, so you could actually discharge from the hospital without knowing it and be put in a long-term unit in the same building. But that would be a transition because everything falls apart. Information isn't tracked. People don't have appointment setting. People don't get the care they need. There's a tremendous, and so there's a huge emphasis in the US at looking at preventable readmissions because it's a marker of how people are paid or not paid because it's looked at as a big expense. 50% of the US health system money is spent in the last year of life. 50% of all the money in our very bloated system is spent in the last year of life, which means that if you can do anything to solve to that last year of life, anything administratively, anything that helps with coordination of care. Because what's happening is that when you have a fee-for-service, you go to the hospital and they provide everything, right? And you don't even know that that doctor doesn't work for the hospital or that that lab is going somewhere else. That's not within your experience.
You find out in the bill.
What's that?
You find out in the bill.
So you find out in the bill. So, which is now illegal. And most people don't know it. So in the goals towards price transparency on prices we don't know, something that was passed, which I actually have that here, the No Surprises Act. The No Surprises Act passed and said that you need to get a signed good faith estimate from anybody who comes in about anything they could possibly pay out of pocket. And you need to provide that good faith estimate 3 days before they're seen, including if they're seen in the ER. Okay, thank you. Thank you. I want everybody to think about how you know in 3 days you're going to have an emergency and need an ambulance, and that ambulance can capture your signed consent.
I will tell you, but then you'll have to burn us.
Okay. Well, we'll try to avoid that.
That's why we all agree we're taking lifts to the hospital now and avoiding ambulances.
Because so what this is doing is changing a total workflow problem with the U.S. health system. And the thing is that everybody in the U.S. health system tends to wait until fines are being doled out. When we had the introduction of electronic health records here, everybody's like, oh yeah, it's happening. And the US government kept saying, you have to move, you have to get computers. And I remember being at a Christmas party and talking to a surgeon, and he's like, I don't know what they're talking about. I've already done the innovation. I have a computer in my office. Said, I think, sir, we have a ways to go. So as that happened, nobody paid attention. And then the U.S. health system said, everybody's going to be fined who's doesn't have any HR this year. So you had this little company called Epic. Some of you might have heard of it. They had 7 salespeople. I love this part of the story. 7 salespeople that year, 7.
Female CEO.
And female CEO. And they were ready, right? They had built a solution thinking about what was happening in the U.S. health system and solved to that, which is what I want to empower all of you to do. Know where we're going, think about your solution, and solve what has not yet been solved. Because with those 7 salespeople, they went around and the first year captured 80% of market share. And well over a decade later, they still have over 60% of market share. And I was there at the time while everything was happening with the HRs, and there were 300 really good solutions. And I'd say at least 200 of them were better than Epic. It's not always about how great your solution is. Sorry. You need to be good enough. What do you solve for the people who will pay for that solution? Your buyer almost never is a patient, right? Unless you have some sort of low-cost thing that you're selling to patients. Your buyer usually you will never get a chance to meet and will have no interaction because there is no one buyer. There is a person paying for the money, and there is another person paying, and there's a third person paying. So we talk about how can you solve to the decision maker who can authorize to purchase your solution. And be a trusted consultant for them. I have a lot of stuff on value-based care at my website. It's firstnamelastname.com, gailzahtz.com. I feel like I'm out of time, even though I barely gotten started. Somebody want to tell me if I can keep going or no?
8 more minutes.
8 more minutes. Man, this is tough. They're tough. So let me go back and give you some sort of like overview on how the money goes. So this is traditional Medicare, which is CMS, Centers for Medicare Medicaid Services, authorized the release of money. And the patient goes and sees a doctor. The doctor sends a bill to CMS. CMS pays 80% of the bill. The other 20%, the patient is required to find a way to cover. So the patient ends up getting a secondary insurance to cover the other 20% or pays for it out of pocket. But that is only paying for what is called Part A and Part B. So Medicare Part A is what you would call your hospitalization. Medicare B is what you would call outpatient care and your doctors. Medicare D is your drugs. Your drugs are not covered by your full Medicare, so you need to carry another insurance to cover your drugs. Now, what entered in here that's called Part C is called Medicare Advantage. Medicare Advantage takes a private insurance company, and that private insurance company receives the money from CMS. I'm going to show you. Okay, so they receive the money from CMS, but they receive 100% of the total cost of care, which is the risk-adjusted benchmark. That Medicare Advantage organization then distributes all of the money to the providers. So all of a sudden you're thinking like, oh no, the buyer's the hospital. Really? Because if half of their population is on a Medicare Advantage, no, your buyer's the Medicare Advantage plan, right? Because they're receiving 100% of the total cost of care. 48% of 65 and plus are permanently disabled or on Medicare. The other piece, and we just don't have time to get into sort of like all of the different models and how this is moving, but basically what is happening is that CMS will be giving it to a pay provider, and that pay provider will create relationships called participating provider relationships, and from that they will then pay their doctors in network, but the beneficiary, the patient, can see anybody. So suddenly these pay providers become a buyer for you also. The short answer being that if in your pro formas you are planning on independent doctors being your buyers, I would suggest a rewrite. Because there's hardly any independent doctors anymore in the US. And those that there are have very little money. They're struggling just to get by. And they're getting eaten up all the time. So your buyer will be this kind of pay provider, this middle person. And then I'm not sure, so here's a couple of pieces that go into it. A panel is the group of all of the beneficiaries that are being served. So a panel is like your population. Some people may hear census. Census is usually like heads in a bed. How many people are you actually serving? Whereas your panel is how many people are you accountable to take care of? Who do you have a financial responsibility to take care of?
So your budgets will be aligned to your
Panel. Yes. So if you have a pay provider that has a panel with a heavy end-stage renal, which is a separate diagnosis, a separate mark in the US, then you know that an end-stage renal solution is going to be very good for that pay provider because they're trying to contain the costs of that panel. All of your doctors groups are generally going to be in some kind of accountable relationships already, and so everybody's going to be carrying panels. Your capitation is, let me explain capitation against benchmark. So an accountable care organization, in this case I'm using an ACO REACH, which is one of the accountable care organizations. An accountable care organization says that we're going to have risk, we're going to get paid for better outcomes, lower costs, and better patient experience. That triple aim, remember, lower costs, better care, better experience. We're going to share that with our providers, so that everybody has skin in the game and is supposed to be working with each other to provide the best care at the lowest cost with the best experience. An accountable care organization can be your only employer. So you can be an employee, a doctor who works for an accountable care organization, or, as is more often the case, you will have several ACOs that are working within a health system and a practice that is aligned with multiple models. So you can have a practice working with Medicare Advantage, working with an ACO, working with some state programs, and that doctor will almost never know what is covered when they see a patient, right? So what you're solving to needs to solve towards the whole process, right? Because that doctor's office is never going to be able to say, oh, I know the perfect patient who will be paid for this free transportation thing that they're selling. Like, they're just not going to know that. So it's working into the workflow and helping the providers do their job better. Not clinically, they're not so interested in you helping them clinically. They're super interested in you helping them with efficacy and payments and communication and data. They are so overwhelmed. It is not a good time to be primary care in the US. Yeah.
The only thing I wanted to clarify on the ACO pays, they get the plus fee for service, which is why
So-
they don't ever want to refer anything out. So if you are in an ACO and they don't do breast cancer very well, you can't go to a center of excellence that is good for breast cancer.
So,
You have to stay there.
yeah, so it depends on the open or closed network. So Medicare Advantage works almost exclusively on a closed network, which says that you're super penalized if you see a doctor outside. The ACO, general ACOs are going to deeply encourage you to stay within their group. Some of the newer models are still paying even if you leave a different state. So one of the big pushbacks, if you remember that chart where I showed managed care and that sort of thing, one of the big pushbacks was we want to see our own doctors. We don't want you to tell us. So somehow everybody has to be accountable to someone and letting you see. They're going to pull me off with that. So I have you're pulling me off, aren't you? See? Boo! All right, so I'm gonna end with this. When I talk to general audiences not in healthcare, I talk about your superpower. I am confident that you were born with a superpower. And your superpower is at the intersection of where your passion, your experience, your skills intersects with what the world needs most from you. The intersection of what you love and what you're great at and what the world very deeply needs from you. And you've lost that because life's awful, right? We get crushed, we get disappointed, we get lied to, we try and we fail, we raise money and we lose it, or we build something great and we don't raise the money, or we raise the money and we keep